This is session 6 from the 12 course session lectures about maternal shock and maternal collapse. And in this session we will discuss treatment. And the treatment is treatment of the cause. Why women die is the key to understand the grounds on which you base your treatment. Why should a woman die wherever in the world, developed or developing, after birth, hours after birth, due to massive hemorrhage? Why should a woman die of sepsis? Why should a young woman die because of preeclampsia? To understand the impact of this huge population of women who die every year, I will ask you a question. What is the largest stadium in Europe? If you think it's Anfield, well, you're wrong. It's not also Old Trafford. Then it's the Bernabeu. No, actually, it's the Camp Nou. 99,000 and more people can gather in the Camp Nou. I want you to look closely at the people here. They are not numbers. They are human beings. They want to live. They want to survive. They want to enjoy life. These women who die and are buried annually amount to full 5.5 Camp Nou stadiums. They are not numbers. Again, they are mothers. They are wives. 529,000 women are buried every year. And it is because of what? Why do women die? Well, the WHO already answered this question. They said the women die due to causes that we know. They die of hemorrhage, of hypertension, of sepsis, of complications of abortion, etc., etc., etc. And this has led to acceptance of maternal death. When someone comes to you and tells you, I have a patient who died yesterday, and he is so sad, and you tell him why, and he tells you, well, she was a massive placental abruption, massive antepartum, then massive postpartum, and she died. And so you say, well, okay. No, it's not okay. It's not okay. When you in your heart feel that it's not okay for a woman to die out of hemorrhage or out of sepsis or out of whatever preeclampsia, then we can look for a cause. There is a cause. These are not the causes. The WHO deceived us. These are the conditions which led to maternal death. The patient did not die because of postpartum hemorrhage. Postpartum hemorrhage is treatable. There is a treatment. Then she did not die of postpartum hemorrhage. She died because we did not take the proper decision at the proper time. So this patient was not saved. The condition that potentially can lead to mortality did lead to mortality. But this doesn't mean that the patient's cause of death was postpartum hemorrhage. There must be a cause, and the causes are the causes that we will talk about in order to address the treatment of shock are: number one, the delay in the diagnosis. The delay in the diagnosis, either in the diagnosis of shock itself or in the diagnosis that we have a shock eliciting event, or the inadequate action due to underestimation of the deception that we talked about in session 2, how obstetric patients deceive us. They go into shock and we think they are okay, and actually they are in shock. Sometimes it's because of logistics, notification of the seniors, the time they arrive, the awaiting of lab results, and sometimes they are because the guidelines are not clear regarding decisions. Sometimes it's because of wrong concepts that we physicians sometimes have. A delay in the decision-incision time, which is an improper action. This can be due to medico-legal concerns for the obstetrician or anesthesiologist, and we have to address this. Maybe it's an anesthesia problem. They would rather not enter into this fight. Sometimes it's because of wrong concepts. So these causes interact and interlace, and we have to understand them clearly so we can fight for maternal lives. So the first thing we have to discuss is the diagnosis of shock. The definition of shock is inadequate tissue perfusion. This definition just keeps popping up in your back mind that you are waiting for shock. You are treating actually shock, and shock is deficient tissue perfusion, when actually you are not treating shock. You are treating a shock state, and the shock state starts by a shock eliciting event. It doesn't start by shock. So I should treat a patient once there is a shock eliciting event. This is when I start to treat. But putting in my back mind that the definition of shock is deficient tissue perfusion, you may be just waiting for shock subconsciously. I'm not saying that you are intentionally delaying treatment. No, it's in our back minds. What is shock? Shock is deficient tissue perfusion. What am I treating? I'm treating shock. When actually you are treating shock state, not shock. Shock is a very late event in the process of the cause that leads to maternal death. So I want the definition in your back mind is that you are treating a shock eliciting event. Sometimes it's the risk assessment. As I said, we have a deceiving phase. If you are not quite aware of this and you have not seen session 2 of this lecture, you may be deceived. While if you start treatment early, you are in a better condition. Shock still small and your actions will have good impact. If you wait till tachycardia, then we are at the end of the compensated phase. And now your actions are still good, your actions will have an impact, but this means that the shock, the monster, is getting bigger. If you wait till decompensation, you are at the break-even point. The monster is big and your actions are strong, so you have to act fast. If you wait till acidosis until DIC occurs or multi-organ death, your actions are smaller, and the monster is getting bigger, darker, and you end with the red monster, which is the top level of the game. The only action you can do at these stages is to stop shock, is to control the cause. Once you have treated the cause, you control the shock. The patient will not deteriorate one step further, she will start to improve. Patients have strong will to live. Patients have strong bodies to fight. The thing is, allow her to fight. Stop the shock at this stage and allow the patient to fight. And then the delay in diagnosis may be delay in the diagnosis of the shock eliciting event. What I mean is there is a shock eliciting event, but you are not aware that this will lead to shock. Although the diagnosis is very clear. All criteria of severe in any obstetric shock eliciting event means that it has reached a shock eliciting stage. Severe preeclampsia, major hemorrhage, massive hemorrhage, severe abruption, and severe sepsis. This means that the monster is unleashed. What should you do? You should start running. Once there is criteria of severity, you start running, so as you beat the shock in the race. And don't pacify yourself, and don't come to a patient with severe hypertension or severe preeclampsia and think that, well, she looks okay. No, you are pacifying yourself. Since there is criteria of severity, then the monster is unleashed and we are going into shock. Now, if I have diagnosed correctly the shock and the cause of shock, then the life of the patients depends on the actions I will take. What actions will I take?
All lectures are based on Tocqueville textbook, your one-stop, postgraduate study source, and decision support platform. You have 14-day free full access trial. Follow the link in the description to start your trial. Remember to hit the subscribe button, and if you find this video useful, please like and share.
So what actions will you take? The assessment of shock and resuscitation, or the diagnosis of shock and treatment? Because these two are different, with two different objectives. Actually, resuscitation is not intended to treat anything. Resuscitation is just to keep the patient alive so that you can do the treatment of the cause. So both of them has to be done simultaneously, at the same time. You are resuscitating and at the same time you are attacking the cause. You are stopping the cause. So long you are doing resuscitation and you are not addressing the cause, you are doing nothing regarding the fact that the patient will die, because this is an ongoing shock state. It's ongoing. So you resuscitate and the patient at the same time is deteriorating. But if you treat the cause early, now we are talking survival, because what happens is that the patient goes into another state from the ongoing hemorrhage to controlled hemorrhage. So the shock state is controlled. The resuscitation you will do will have an effect because there is no deteriorating factor. So both of them has to be done simultaneously. And once you control the bleeding and you control the shock, the patient will not deteriorate one step back. Actually, she will survive by her own compensatory mechanisms. Just give her a chance to live. Give her a chance to fight for her life. Our bodies are so strong. Our bodies can withstand shock state if this shock state stops. Now we are in the survival phase, and she will improve even by her own compensatory mechanisms. But if you delay the treatment of shock, you go into another state, which is the state of DIC acidosis and multi-organ death. So postpartum hemorrhage by itself is not the cause of death. Postpartum hemorrhage is treatable. If you just arrest the bleeding, the patient's shock state and bleeding is controlled, and so the patient will start to compensate what happened. So the patient will start to recover. She will not deteriorate one step back. If we stop the hemorrhage, why should she deteriorate? She will stay at this phase and then she will start to recover. But if you delay the treatment, nobody can survive this. Some physicians will go on and on and on in the resuscitation and then assessment of shock, and then resuscitation and then assessment of shock, and they don't perform anything regarding treatment, regarding arrest of hemorrhage, regarding arrest of severe preeclampsia by removing the placenta, regarding arrest of sepsis by removing the septic focus. They will not go to treatment. They will just resuscitate and resuscitate. So there is no chance of survival. Nobody can withstand this. This cycle of assessment resuscitation has two main causes. Number one, guidelines which don't give me clear decisions. Number two, wrong concept that resuscitation should be done first and then we operate. And this is a deadly concept. You can never resuscitate before you operate, because the patient is deteriorating while you are resuscitating. So it has no end. It's a positive, vicious circuit. The improper action, the wrong move. The wrong move is either you are too concerned about medical legal, you sometimes refrain from interfering. The second thing is the anesthesia. Sometimes the anesthesia would rather not interfere. It's like the genie in Aladdin. Why are you bringing me into this? This is an obstetric case. It's a severely morbid case. You are the obstetrician. If she takes anesthesia, then I'm involved in the fight. Sometimes it's like this. And usually I would put in writing the request for anesthesia. And I would refer that this is an emergency and this is urgently and it has to be done now, in spite of the low hemoglobin, in spite of acidosis, in spite of everything. We have to remove the septic focus. We have to remove the, we have to deliver the patient. We have to go for treatment of the cause. The third cause of an improper action is the wrong concepts that some physicians have. And the cause of wrong concepts and the cause of having medical legal problems and anesthesia quarrels in late night shifts is the guidelines if they don't give you a clear time decision. If you have a clear time decision, these guidelines will protect you in the face of any inquiry. They will protect you when you are requesting anesthesia, and they will give you the right concepts. Guidelines are supposed to give me decisions. And what are decisions? Decisions are a certain sign given in the guidelines, and when this sign is present, you take a certain action in a certain time frame. These are the basics to save a patient's life. And the diagnosis decision time, the life of the patient's depends on it. And then when you take the decision to embark on surgery, there is a decision incision time. And this time as well, the life of the patient depends on it. So what do guidelines give me? If you go through antepartum hemorrhage guidelines, you will not find a decision. The ones we specify here, a sign followed by an action within a reasonable time. This is not specified. If you go for postpartum hemorrhage, you'll find hysterectomy mentioned as the last surgical treatment. They mention balloon, they mention devascularization of the uterus, compression sutures, but hysterectomy comes as the last option. And in a small paragraph, although they stress that this is the definitive treatment, and they stress that do not delay it, and they stress do hysterectomy sooner rather than later. What is sooner? What is later? And then if you go for sepsis, either during pregnancy, you won't find a clear mark what to do when. And if you go for the sepsis following pregnancy, which is puerperal sepsis, and search for the word hysterectomy, you will find no match. The whole guidelines, 23 pages, they don't mention hysterectomy in the treatment of sepsis following pregnancy. So where do you find the guidelines that will give you the timing and the decision and will support what I am saying and will support you in court? These will be the 3 basic guidelines you have to address when you are treating shock. Maternal collapse in pregnancy and puerperium will give you the decision, will give you what is the definitive treatment of every case in the obstetric practice: antepartum, bleeding in early pregnancy, postpartum, preeclampsia, sepsis. All this will be present in this guideline. Guideline number 56. But it will not give you the time to incision. It will tell you that you have to do an incision, but where is the time? Then you will have to resort to 2 guidelines. One of them is the National Confidential Inquiry into Patient Outcome and Death, and this is UK guidelines, and the Caesarean Birth Guidelines, which is the NICE guidelines that was published in 2021. The NICE guidelines for Caesarean section categorize Caesarean section with respect to urgency into category 1, which is immediate Caesarean section, life-threatening condition for the mother or fetus, and then category 2, when there is compromise to the mother and or fetus, but there is no immediate life-threatening condition, and then category 3, there is no compromise, but delivery needs to be expedited, and then category 4, when there is no compromise and delivery will be planned according to the circumstances which suit the woman or the healthcare provider. What is even better is that you get the timing that we have been looking for. If it is category 1 and there is immediate life-threatening condition, then usually from decision to embark on surgery to incision, usually within 30 minutes. If it is category 2, where there is compromise but not life-threatening condition, then the time is about within 75 minutes. So at last, I have the time that I needed. And then the other guidelines that give you timing, which is very similar to the Caesarean timing, but instead of saying Caesarean section, we will say intervention, is the National Confidential Inquiry into into Patient Outcome and Death. And they classify interventions. Immediate, which is an immediate life, limb or organ saving intervention. That's why I said many times there is no contraindication to life-saving surgery. And then the urgent is when the intervention is for an acute clinical onset or clinical deterioration of potentially life-threatening condition, a shock enlisting event, and there is starting deterioration. And then expedited is when the patient is requiring early treatment, but the condition is not an immediate threat to life. And an elective when intervention is planned or booked in advance to routine hospital admission. So the intervention to save patient's life is categorized here according to these 4 categories. So we can summarize everything in one table. This is the Caesarean section category 1, which is according to intervention, this is the immediate or the break-in intervention. And this is indicated within 30 minutes. The time interval, decision to incision, is 30 minutes. From the decision to embark on surgery up to the incision within 30 minutes. And this is indicated in life-threatening conditions. And in the NICE guidelines, they specify examples like suspected uterine rupture, major placental abruption, cord prolapse, fetal hypoxia, but we will talk shock. So we will specify it by shock events. If there is acidosis, DIC or multi-organ dysfunction, this is a life-threatening condition. If in the modified early obstetric warning score, the patient scores more than or equal to 4, or 3 in any one single item, this is a life-threatening condition. If we talk pre-eclampsia, we'll change the terminology a little bit. Eclampsia is life-threatening condition. HELLP syndrome is a life-threatening condition. If we talk sepsis, then we will have to change into saying the patient is in septic shock. And then we have category 2, which is the urgent intervention. Within 75 minutes from decision, I should have performed the incision. And this is in the conditions of maternal or fetal compromise with no immediate threat to the mother or the fetal life. We will translate this to medical terms. This is English. Compromise is English. What does it mean? It means I am in a decompensated shock stage. So there is no immediate life threat. There is still one stage to go, but it's imminent. So within 75 minutes, 1 hour and a quarter, you have to have performed the incision. And this is the modified early warning score of 2 or 3. And this in preeclampsia, we'll say this is the severe preeclampsia with organ dysfunction. And in sepsis, we'll say this is the severe sepsis. And then category 3 is the expedited. I need early birth. It's not urgent right now, but we have to plan it carefully, because we have no maternal or fetal compromise, but we have an imminent threat to the mother and fetus. And this is the compensated shock. When you have diagnosed a shock eliciting event, but still the patient did not go into deficient tissue perfusion. So I am in a shock state, I'm in the first stage of the shock state, and so the MEOW score, the modified early obstetric warning score, is 0 to 1, and this will translate in preeclampsia as the severe preeclampsia with only the hypertension, but I don't have organ dysfunction. And in infection, it will be the occurrence of sepsis. Infection plus 2 criteria of SIRS. This patient will deteriorate. I have a threat to her condition, and she will go into compromise. Of course, if she goes into compromise, you shift the indication from category 3 to category 2, or from intervention, which is expedited, to intervention, which is urgent. And then the fourth is the planned, and we don't have in shock a patient who will plan, whom we will plan an intervention. If we will plan an intervention, then there is no shock eliciting event, there is no shock state. This is the regular obstetric practice. And if it is sepsis, then we are talking infection only, so I just need some debridement of the wound or something. I will do it in the after booking her in the OT. We put our guidelines like this since the 90s. If a patient is in life-threatening condition, we were blamed if we do not perform the incision within 30 minutes. And the concept that there is no contraindication to life-saving surgery was very firm in our establishment in Ain Shams University. I know that some of you, although this is evidence-based and the timing is set, but they will have a problem of going into theater with a critically ill patient with DIC or with severe morbidity because of many wrong concepts that they have been adopting for so long time. So what concepts do we need to change? Actually, there are concepts regarding resuscitation. And we will discuss this in session 8, the session of resuscitation. Why we are afraid of underestimating blood loss, not overestimating blood loss. And why not to give crystalloids more than 2 liters? Why should we avoid colloids? Why no whole blood replacement? We just give packed RBCs and fresh frozen plasma in a preset ratio. We do not give whole blood at all. And the lab guided is a method to replace or replenish the lost components, but they are not used for volume replacement. When you are replacing volume, you rely on the preset protocols and the estimated blood loss clinically. And there is no bicarbonate to correct acidosis. This is totally wrong. Acidosis cannot be corrected except by treatment of the cause. So as DIC. DIC cannot be treated without treating the cause. You cannot give fresh frozen plasma and give platelets to a patient without removing the cause, because the patient will use the fresh frozen plasma and the platelets you give to create more intravascular coagulation, and then the fibrinolytic system will lyse this, and FDPs will increase, and there will be renal failure, and there will be consequences without treatment of the DIC. So actually DIC and acidosis, which are the two major risks and the two major pathologies that lead to patient death, they have no treatment. You have to treat the cause. And hyperkalemia is not diagnosed except by a potassium level more than 5.5 milliequivalent per liter. They are not diagnosed by ECG changes. They are not diagnosed by clinical criteria or anything. It has to be lab diagnosis. So these are some wrong concepts in resuscitation that we will discuss later in the resuscitation. Now we are concerned with treatment. I find some wrong concepts in treatment that need to be changed. Although maternal collapse in pregnancy and puerperium, the green top guidelines number 56 will list the definitive treatment of every case. If there are definitive treatments for every high-risk patient and every shock eliciting event in obstetrics, why do patients die? Patients die because of wrong concepts like resuscitate then operate, which is total nonsense. You can never resuscitate a deteriorating patient. You resuscitate from one side and the patient deteriorates from the other side. So this is a positive vicious circuit. It has no end except by death of the patient. So we resuscitate and we operate. If the definitive treatment is an operation, we have to go for operative treatment of the cause. A concept of that hysterotomy is a crime. We should not perform hysterotomy. And this is totally wrong. Hysterotomy has indications. If the indications are there, then you have to do it. Hysterotomy is not a crime. Hysterotomy is a life-saving procedure. And another concept is that no cesarean section on dead fetus. I don't know where this came from, because actually, in cases of placental abruption and the fetus is dead, a dead fetus in placental abruption is one of the criteria of severe abruption, which means severe bleeding, which means severe hemorrhage, which means you have to go for treatment of the cause as fast as you can. So if you wait, the abruption will increase, the covillary uterus will be there, the atony will be there, the patient will go into postpartum hemorrhage after the antepartum hemorrhage, and she will go into the IC. So we have a lot of complications if we wait. So withholding definitive treatment because the fetus is dead, if the definitive treatment is cesarean section, go ahead and do it. You are saving the patient's life. Another thing is that hysterectomy is the last option, and I face this in two conditions, in cases of postpartum hemorrhage and cases of puerperal sepsis. In cases of postpartum hemorrhage, hysterectomy is the last option because in the guidelines it's written in the last paragraph. After balloon, after devascularization of the uterus, after compression sutures. So this gives the impression to physicians that since it's the last paragraph, then this is the last option. And they don't go for hysterectomy except if the patient is severely morbid. And this is total nonsense. Hysterectomy is the definitive treatment. So when you need definitive treatment, and this is discussed in postpartum hemorrhage in the conditions that lead to maternal death, the second session, you can have a look at it. And we discuss when to do hysterectomy firsthand. You don't try the less definitive treatments, which are the balloon or the compression sutures or the devascularization of the uterus. You go directly for hysterectomy because this is the definitive treatment in the ill patient. The thing is that you can do it before the patient is morbid. And the guidelines, they don't state this because they always tell you in postpartum hemorrhage, sooner better than later, but they don't tell you that sooner is when the patient is still in the compensated or decompensated phase. You don't have to wait till acidosis and DIC. Of course, this is governed by many things, the will of the patient and the counseling and all this. I keep it in my mind while I'm talking, but I don't want presence of hysterectomy as the last option in the guidelines and presence of hysterectomy sooner better than later without a definitive time to deter you from doing hysterectomy as a life-saving definitive treatment of postpartum hemorrhage and of puerperal sepsis. It's really very frustrating that you find patients with puerperal sepsis and the doctors are giving anti-infectives after anti-infectives and after anti-infectives as if anti-infectives is the treatment. Actually, no. Anti-infectives will not treat an infected uterus. I'm not talking about uterine contents. Uterine contents, you can evacuate them. But sometimes the infection is in the uterus itself, the myometrium and the serosa and the deciduous. So you have, at these situations, you have to do something called source control. In all infections, there is no treatment of sepsis without source control. You have to control the source of infection. And in puerperal sepsis, the only control of the source of infection will be through performing hysterectomy in cases of puerperal sepsis, and the uterus is the source of infection, not the contents of the uterus. If it's the contents of the uterus, you have to do evacuation. And then another concept is give more time to fetal maturity. Yes, I agree, we need more time to fetal maturity. In many cases, this is a case of preeclampsia, for example. And then the patient is in severe preeclampsia. Okay, which severe preeclampsia? Because I see in the guidelines there is a discrepancy between severe preeclampsia with no end organ dysfunction, just by hypertension, and severe preeclampsia with end organ dysfunction. If the patient is severe preeclampsia with end organ dysfunction, my God, the organs are failing already. What are you waiting for? You have to balance the time you want to give versus that the patient doesn't have that time to live. So it has to be perfectly balanced. And in the guidelines, this balance is not well stated or well articulated. And so I will explain the guidelines. I'm not talking outside the guidelines. I will explain the guidelines when we come to the session of preeclampsia. But always keep in mind that the fetus needs more time for survival, but the mother may not survive this time you are giving to the fetus. And then one of the concepts that is deadly is that DIC, or bad general condition, is a contraindication to surgery. Well, it's exactly the opposite. Presence of DIC, or the patient is in severe shock state, this is an indication to perform a life-saving surgery. And there is no contraindication to life-saving surgery. And there is no other way to save the patient. DIC will never get better without removing the cause. Acidosis will never improve without removing the cause. So actually you are stuck in the corner. Yes, I know the patient is DIC. Yes, I know the patient is in bad general condition. But you have to perform surgery. We started this presentation by asking the question, why do women die? And they die out of delay in action. Delay in the diagnosis, delay in the diagnosis decision time, or delay in the incision time, which is the improper action. And in order to save women's lives, we will do proper actions at proper times. We will diagnose shock, and we'll diagnose shock eliciting event properly. We will not be deceived, so we will have the diagnosis decision time properly timed. Guidelines with no clear decisions, we will try to clarify decisions in them and to set our decision times even if they are not present in the guidelines. We will have no wrong concepts of treatment, and we will set the proper incision time regarding the life-saving interventions. If it's a life-saving procedure, within 30 minutes. If the patient is compromised but not in life-threatening condition, it's 75 minutes. And if the patient is not in compromise and not in life-threatening condition, but yet she is in danger because there is a shock eliciting event, then we plan according to next available theater and according to the balance between the threat and the risks we are taking without being deceived. We know shock eliciting event, a monster is unleashed, and we will start running in the proper time with the proper pace. The seventh section of this lecture will be the resuscitation.